CheckMate 238, as you probably remember, was a large, I thought, well-done randomized phase 3 study that was blinded of Nivolumab versus ipilumumab adjuvant therapy given for a year. Primary endpoint was relapse-free survival. Secondary endpoints included overall survival, toxicity, tolerability, quality of life. Exploratory endpoints were preclinical endpoints, which are not worked out yet, some of which are ongoing, actually, at my own institution, and distant metastases-free survival. So at 4 years of follow-up in all patients, so 48 months plus, there still continues to be a major advantage for Nivolumab versus the active comparator of ipilimumab. I think we're talking a little bit over a 50% relapse-free survival rate. It's probably 52 or 53% at 4 years of follow-up for the Nivolumab arm. And the hazard ratio continues to be about 0.68. The p-value continues to be something like 0.002. So the benefit of Nivolumab is maintained at 4 years of follow-up, as it was seen at 3 years and at 18 months of follow-up. But now for the first time, we have data from patients who had in-transit metastases, and there are about 150 such patients, which is a fair number. And there's, again, clear benefit for Nivolumab versus the active comparator of ipilimumab. The data suggests that for the overall group, it's not all that much different for the stage 3B, 3C, 4 resected patients than for those who have the in-transit metastases, which these days, I guess, are either 3B or 3C, depending on the AJCC addition that you use. So as you can imagine, if the drug worked in nodal metastases, it also works in those who have in-transit metastases, potentially without even having nodal disease. And that's important because it says if you have a patient with a primary melanoma who then develops an in-transit metastasis between the primary and the draining nodes, even if the nodes are negative, there's still evidence of benefit for delivering adjuvant immunotherapy with Nivolumab. Coming to the distant metastasis-free survival, there still continues to be a 6 or a 7% absolute difference with benefit for Nivolumab compared to ipilimumab. This continues to be clinically significant over time at 4 years. And a lot of people think that the distant metastasis-free survival is a good surrogate for overall survival. In this study, we now have the overall survival data, and the punchline is there's no real difference. The p-value is 0.3. The rate of survival at 4 years for the nivo arm is 88%, 87% for ipilimumab. But if you look at the data, essentially the majority of patients who could crossed over from nivo to ipi or nivo to ipi plus nivo. The majority of patients who had ipi crossed over to nivo. So essentially you're talking about an inherent crossover design, which of course was predictable from the fact that at the time CheckMate 238 was done, if you developed metastatic disease, ipi and or nivo and or the combo was basically approved in almost all the countries where the trial was done. So if you were on the ipi arm and you relapsed, well, heck, you're going to get Nivolumab. Or if you're on the nivo arm and you relapsed, you'll either get ipi or ipi-nivo. So, it almost makes it impossible to interpret the survival. I suppose with more follow-up, there could be a difference, but I doubt it. If you look at the survival curves, 88% at 4 years is pretty darn good for a group of patients that have 3B, 3C, and 4 resected disease by the AJCC 7th edition. So I would say the patients did incredibly well in terms of survival. Certainly, if you go back and look at the 3B, 3Cs, melanoma-specific mortality in the AJCC 8th edition, for the 3Bs and 3Cs, it looks a lot worse than 88%. So I think we did some good here. And if you go back to the ipilimumab alone trial, the EORTC 18071, it certainly looks as if, and you do this comparative analysis, which admittedly is a statistical machination which enables you to compare apples and oranges. You're comparing an ipi-nivo survival curve to an ipi alone survival curve from 3 or 4 years ago. It looks as if there's definite benefit for nivo versus placebo, because in the 18071 trial you had ipi placebo, In the current study, you have ipi-nivo, so you can do this comparative analysis, which has been done. It was presented at SITC last year, and it's being written up for publication. And it'll be presented again as an abstract. It looks like you clearly have benefit of nivo adjuvant therapy for survival compared to placebo. Again, remember, that's not a direct comparison, it's an indirect comparison. But it looks very reasonable, and it looks certainly biologically and clinically significant. So that's the story on 4-year follow-up on CheckMate 238. Of course, next year we'll have 5-year data, and we may have ipi-nivo CheckMate 915 data coming up in the next year. We'll see where that goes.